بسم الله الرحمن الرحيم. Differential diagnosis between mesial temporal atrophy and mesial temporal sclerosis.
When we look at MRI scans of the brain, changes in the mesial temporal lobe can tell very different clinical stories. Two conditions that often appear similar but carry very different implications are mesial temporal atrophy and mesial temporal sclerosis. Both can involve volume loss in the hippocampus, yet their causes, imaging features, and clinical contexts are not the same. One is commonly associated with neurodegenerative processes like Alzheimer's disease, while the other is a hallmark of chronic temporal lobe epilepsy. In this video, we'll break down how to tell them apart on imaging, focusing on key MRI features, clinical clues, and practical tips that can help you make a confident.
Let us first discuss the anatomy of the hippocampus and nerve structures. We are confronted here with MRI T2 coronal image at the level of the hippocampus, which revealed the green arrow represents the parahippocampus, while blue arrow for hippocampus, yellow arrow for collateral sulcus, and finally the red arrow represents tentorium cerebelli. Etiology of mesial temporal atrophy, Alzheimer's disease, which is a common neurodegenerative disease responsible for 60 to 80% of all dementia. A clinical diagnosis can be made by identifying a progressive decline in memory. While in case of mesial temporal sclerosis, which is the most common association with drug-resistant temporal lobe epilepsy. Radiology imaging. In case of mesial temporal atrophy, Alzheimer's disease, the primary role of MRI in diagnosis of Alzheimer's disease is the assessment of volume change in characteristic location, which can yield a diagnostic accuracy of up to 87%. These changes seen as mesial temporal atrophy, particularly the hippocampus, and temporoparietal cortical atrophy. On the left, we can see MRI T2 coronal image showing loss of height of bilateral hippocampi with dilated temporal horns and choroid fissures on both sides. And we have also another image, PET-CT, using radio-labeled glucose analog phage sagittal image, shows decreased phage uptake in both temporoparietal lobes. While in case of mesial temporal sclerosis, MRI is the modality of choice to evaluate the hippocampus. Findings include reduced hippocampal volume, hippocampal atrophy, plus increased T2 signal. On the right side, we have MRI T1 coronal image at the level of the hippocampus, revealed normal hippocampus on the right side, while on the left side there is hippocampal atrophy. Another MRI flare axial image at the level of the hippocampus shows diffuse increased intensity of the hippocampus with decreased volume. Summary of differential diagnosis. In case of mesial temporal atrophy, you will find mesial temporal lobe atrophy plus temporoparietal cortical atrophy plus no signal changes. While in mesial temporal sclerosis, there will be evidence of hippocampal atrophy plus increased signal of hippocampus. Look to the intensity of the atrophic hippocampus. If it shows diffuse hyperintensity, it will be mesial temporal sclerosis. but if it shows normal intensity, it will be mesial temporal atrophy. Let us take short brief about causes of dementia. Dementia can be due to treatable diseases or non-treatable diseases. In case of treatable diseases such as subdural hematoma, tumors, hydrocephalus, or in case of non-treatable diseases such as Alzheimer, frontotemporal lobar degeneration, vascular dementia, and dementia with Lewy bodies. Differential diagnosis of non-treatable causes of dementia. Look to the brain lobes. If it shows global atrophy, it will be vascular dementia. Look to other signs such as deep white matter lesions, lacunes, or strategic infarctions. Or it shows specific atrophy to certain lobes such as symmetric temporoparietal and mesial temporal lobe atrophy in case of Alzheimer's disease, or asymmetric frontotemporal lobes atrophy as in frontotemporal lobe degeneration, or no specific abnormality in case of dementia with Lewy bodies. Strategic infarctions occurs in area control cognition and behavior, and this include basal ganglia, thalamus, infromedial temporal lobes, and angular gyrus. How to measure the following: global cortical atrophy and atrophy of the medial temporal lobe in case of dementia. Measurements of global cortical atrophy GCA scoring. We use FLAIR axial images to evaluate cortical gyri and sulci for detection of global and specific lobar atrophy. It is composed of 4 scores as seen in the diagram. Score 0 equal to no cortical atrophy. Score 1 equal to mild atrophy with opening of the sulci. Score 2 equal to moderate atrophy with moderate loss of gyri, while score 3 is equal to severe atrophy with knife blade gyri. To diagnose hippocampal atrophy, look to the cerebrospinal fluid space above it. If it is dilated, including only choroid fissure, number 1, it is equal to score 1. But if it is including choroid fissure and temporal horn, number 2, score 2. And if it is not dilated, it will be a normal case. And finally, look to the height of the hippocampus. It should be normally from 6 to 10 milli. If below 6 milli, this is equal to moderate atrophy, while if it is less than 5 milli, this is equal to severe atrophy. In case of mesial temporal lobe atrophy, we use T1 coronal image to evaluate volume of the hippocampus in addition to widening of the choroid fissure and temporal horn. Measurements include 5 scores as seen in the diagram. Score 0 equal to no atrophy. Score 1 equal to widening of the choroid fissure. Score 2, score 1 plus widening of the temporal horn. Score 3, moderate loss of hippocampal volume. Score 4, severe loss of hippocampal volume. If the patient is less than 75 years old, score 2 or more is abnormal. But if the patient is more than 75 years old, Score 3 or more is considered abnormal. Lastly, we can talk about Vesicus classification for white matter lesions. White matter lesions can be divided into two entities. The first one is periventricular white matter, while the second one is deep white matter. The periventricular white matter causes mainly due to myelin agliosis, while in deep white matter mainly تبقى due to vascular disorders. In case of periventricular white matter, we have 4 grades. Grade 0, absent. Grade 1, presence of caps أو pencil thin lining. Grade 2, smooth halo. Grade 3, regular periventricular signal extending into the deep white matter. While in case of deep white matter, we have also 4 grades. Grade 0 absent, grade 1 punctate fossae, grade 2 beginning confluence of these fossae, grade 3 large confluent areas.